Malawi has a population of approximately 18 million people, 80% of whom live in rural areas. The people in these rural areas receive most of their health care at district hospitals where there are no medical specialists. This affects the quality of primary care that patients receive. Family medicine, also referred to as general practice, is a medical specialty that gives adequate and comprehensive care to patients of all genders and every age.
My name is John Parks. I am a family physician. I'm originally from the U.S. and I have been working in Malawi since 2015. I am the current head of department for the Department of Family Medicine. I started my role in March of 2017. The Department of Family Medicine was started with its first activity in 2011. It started with undergraduate medical student rotation in family medicine. The department is currently housed within the School of Public Health and Family Medicine, which is part of the University of Malawi College of Medicine. The College of Medicine is one of the colleges, one of the constituent colleges of the University of Malawi. And we are in one of the schools or faculties within the College of Medicine. In our area, in our school, we have 3 departments. We have the Department of Public Health, Department of Health Systems and Policy, and the Department of Family Medicine. One of the ideas behind why we are where we are is that family medicine as a department has a feet in both worlds. It has a foot in the clinical world, but also a foot in the public health and systems and advocacy world.
So before joining the family medicine program, I'd worked in 2 district hospitals, Balaga and Salima. So I was the most senior. Of course, in Balaga I was a district medical officer, but in Salima I was a district health officer, and I was the most senior person at the level. And people consulted me if they had a certain kind of emergency or problem. So I felt that I needed more training just to equip myself to be a consultant at the district level. Because before I was always interested in working at the district hospital. And I was excited about it because I know that there are more people that live in the rural in Malawi, so there are more people that need our help. And I was excited about it, but then reaching there, it was a bit overwhelming because of the skills that I had. Despite that people didn't notice that, but I still felt that there was a bit of a gap between the skills that I had and the skills that were expected of me. So when I saw the opportunity that there's this training family medicine, which I had read about, I was very interested. I went to read up on it. Then I applied for it here at the College of Medicine. And then I spoke to Dr. Duli, who was the current head of department for family medicine. And I went through the interviews, and I felt like it met with my objectives in terms of being a consultant at the district level.
Well, I studied my family medicine training. I did my family medicine training in South Africa. But I think the reason I chose this path is, I think, the experience I had when I was posted to the district as a junior medical officer. Yeah, when I went there, I think I got overwhelmed with the responsibility that I had, both clinical and administrative, and I felt very unprepared for the challenge, and felt that my medical training did not prepare me for such diverse responsibilities that were huge, but also very, very varied. And I must say that I didn't know what to call this specialty, but one of the then dean Prof. John Kumwenda started also, identified this as a need, because most medical officers would go to the district, get overwhelmed, and actually leave. And started something they called district competencies, that doctors going to the districts ought to have these kinds of competencies. And I felt that was really important. And I worked there for a while, just like anybody else. I also quit. Went into the private sector, Blunt Adventist Hospital, and then I think I got a scholarship to go study, and they said family medicine, but then I didn't know exactly what it involved. But when I went, that's when I discovered that this is the skill that I lacked, and that would have complemented my competencies at the district. So I enjoyed, filling that gap. And most importantly, I think it's about feeling comfortable managing every kind of patient. That's what I can summarize it as, to be able to save life, and also work in those contexts where there are low resources. You often are working alone with no senior backup, and I think that training prepared me for that type of setting. I think what made me and my colleague, my predecessor, I think, advocate for this program is that I think our students are always exposed to the hospital medicine, the extreme medicine, but also that is well resourced, and yet I think they lack a picture of what happens in the primary healthcare, where the saga happens. As you know, that the Malawian population is about 85% rural, so most of the people actually present in the district hospital, health centers, and health posts, and that's where we need the appropriate skill mix to be able to handle those problems. But our training is skewed towards hospital medicine with a lot of resources and the extreme cases of the spectrum of disease. So I think that's why we as a team lobbied for that, and I personally advocated for family medicine, both in the college but also at the moment advocating for it in the Ministry of Health system.
I was a pioneer. We were the first people to start family medicine. I have two other colleagues, Nita and Modai. So we started at Mangochi, but then because it was also the first postgraduate training district site, there were some gaps that were there in terms of resources and maybe other skills. So we also were traveling to Blantyre Queen Elizabeth Central Hospital, which is a tertiary central hospital. The main challenge of being a pioneer is that people are figuring things out, and there could be maybe differences in opinion on how, as students, you think that things should be done, comparing to the faculty, and you don't have anyone to talk to, like someone who has done the training and going to the end and finishing and telling you what the challenges and the obstacles are. So that was the very first challenge that we had. Of course, we had two supervisors who had trained in South Africa, so they had some, at least they could tell us some things, but still, because the contexts were different, there was still some kind of challenge in terms of us being trained at a site where there had not been official postgraduate training.
When the program first started in Mangochi District Hospital, prior to that time, that hospital had not had postgraduate trainees, not had doctors training at that hospital previously in the way that we started the program. And so one of the challenges was integrating into a system that had not had something like that before. So working with the staff, working with the nurses, the clinical officers, the district leadership to explain what these students, what these young doctors were there to do. What was the role of a doctor trainee in this hospital? It was about starting something new, starting something that had not been done before, and then building relationships. And as our first graduates will tell you, and as our faculty will tell you, it was not an easy road. It was a long road, but over time and in building relationships, we see now that we are not where we were with some of our partner sites, and we hope to continue to build and grow those relationships in the future, because it's through these relationships with places like Mangochi District Hospital that we work together, that the students receive strong training, as well as the place that they work can receive good service, receive a benefit from these students that are also working as well as learning there.
Well, I think Malawi is a very, we are still in the low-income country, and primary health care is the most cost-effective ways to reach out to most people, so that we prevent illnesses before they're very serious, and then we need a lot of resources. So I think, for me, I feel like the district level, which is the secondary level, and the primary level, that's where we should be putting in more resources, more health workers, because this is where you prevent and also you can manage your resources.
Thing is maybe two others. Another exciting thing is the success of the undergraduate program. We have had now 8 years of continuous operations in which every year we train these medical students, sending them to the district and instilling to them the values and the approach to the patient that we use. And every year we aim to get even better in how we deliver the program, to make the quality of our education and the quality of our teaching just even better year after year. And so that's a real celebration for the department.
I would encourage everyone to say our system is not 100% just like another system, but I think if you have skills to be able to look at things holistically, look at them differently with a broader lens, and at least start thinking about how to improve systems, then this is the best way to go, best way to train. And I know that working in the districts has a lot of challenges, but I think someone has to be there and be an agent of change.
One of the most important things for us is the people. Financial resources are invaluable, but without the people, you don't have the ability to carry out and deliver on your mission. So these human resource partners have been critical for our success.